Welcome to Spotlight on St. John's. I'm your host, Brian Brown. St. John's University is a unique Catholic, Vincentian, metropolitan, and global university. And St. John's is on a mission to ensure student success. Today, using the Zoom technology, I had the chance to connect with Dr. Harlem Gunness, Associate Professor in St. John's University's College of Pharmacy and Health Science. Dr. Gunness has a unique career in public health. We talked about his own background and the COVID-19 health crisis. Let's watch. So today's episode, we're going to talk to Dr. Harlem Gunness. He's an associate professor in the College of Pharmacy and Health Service Sciences at St. John's University. Dr. Gunness, welcome to the show.
Thank you. It's a pleasure to be here.
So a lot of ground we want to cover today, but I really want to get to know you a little bit better and have our audience get to know you better. So if you could tell us a little bit about your own background and how is it that you found your way to St. John's University?
Okay, so I did an undergraduate degree in community health education, and I absolutely fell in love with it once I started to focus on that major. And that led me to work on infectious disease at the time after I graduated. And it so happened that once I completed my master's in public health, it was around the time right after 9/11 and then right after the anthrax attack. And at that time, I got laid off, believe it or not, and then I ended up working with the CDC, Centers for Disease Control and Prevention, as a public health specialist. And because of that infectious disease background, doing research and doing education and developing programs and interventions to mitigate or reduce infectious diseases, CDC hired me as their consultant to work on the SARS outbreak that was happening. So they deployed me at JFK Airport to develop a plan to prevent the introduction of SARS. So my responsibility there was to really assess hospitals' capacity and capability to manage highly infectious disease that if it were to be introduced or enter the country at ports of entry. So that was a huge undertaking. And then I left that, and at the time, New York State Department of Health were hiring public health preparedness representative to work on bioterrorist attacks. So in that responsibility, I started to work with hospitals in throughout the Northeast, the lower Hudson Valley region, in guiding them and helping them develop and prepare for what is actually we're experiencing now, an influx of patients with a highly infectious communicable disease. And then I left that to go back at CDC as a civilian federal employee. And then that allowed me to get into the US Public Health Service, which is one of the 7 uniform military services and an elite component of the military where we work to prevent diseases from spreading in the US. So we're sort of like the national defense for infectious disease. And infectious disease, particularly in situations where it's an emergency, like the pandemic we're experiencing now, or the Ebola outbreak. So it really, I'm very fortunate that my public health degree has really allowed me to tap into many different avenues in public health and very different disciplines where it helped to sort of make a difference in communities, in populations, to improve health or prevent diseases.
Terrific. Now, this is not a trick question. Did you see this coming? Given your background, your work experience, your research. Okay, tell us about that.
Yes, absolutely. Without a doubt. I didn't, one cannot predict exactly when the outbreak will occur, But having recently, just a few years ago, worked in the Ebola response, we see that something like this, and it will continue to happen. Diseases, as we know, may change over time, or new diseases may emerge. So we need to be very prepared for this. And we see right now what we're living and what we're experiencing, the ramifications of a disease that can spread very quickly, very rapidly, as well as how infectious it is, and the the casualties it's causing.
So Queens County, a borough that you and I both love and know well, is really at the center of the COVID-19 crisis in New York City. Could you talk a little bit about why you think that is and how it got so bad so quickly in a borough like Queens County?
Yeah, that's a very good question. So when you think of disease transmission, and you think of the characteristics of the disease, and you sort of tie that in with the characteristic of populations and urban environment, then you really have to weigh a lot of factors. So, quite often diseases, the factors may lead to the spread, or how fast a disease can spread, can be environmental factors, such as overcrowding. It can be communication factors, such as, did we get the information on time or early enough for us to change our behaviors? You have to think about the capability and capacity of the resources we have. Do we have the ventilators that's needed now for the ill patients? Do we have the capacity of the healthcare force to respond to a disease, and to respond to a disease that's traveling so rapidly? So there are many things to look at from many different levels and many different disciplines. Do we have the laboratory testing to test for the disease? How reliable and valid are these tests? Do we have the staff available to administer the test? Do we have the funding available for us to afford the test and make it mass produce it, such that it is available to the local communities? What about the community's beliefs? And what about the community's knowledge about disease, especially when you're dealing with a highly infectious diseases that where things are changing rapidly every day, every week? There's a new finding, there's a new protocol, there's a new suggestion. So some communities may not be able to keep up with these changes and adapt to these changes. Behaviors, community behaviors, individual behaviors. There's a process for us to change our behavior. So a lot of factors we have to think about, not just the disease, but sometimes the external factors as well that can influence or exacerbate its progression.
And some of those external factors that you've mentioned are very prevalent in a borough like Queens County, a very densely populated borough, a very diverse borough in terms of languages spoken, the immigrant population, how people live and work and shop, and transportation factors. What do you think, mindful of all this now, and mindful that the best history is always written after an event, what did the government at all levels, city, state, and federal, what did they do well, and what could they have done better in this particular situation?
It's funny you say that, because when an incident occurs, we do what's called an after action report. And the after action report really outlines what are the strengths and weaknesses of the response. So with some of the factors, I want to sort of piggyback on some of the things that you mentioned. So from what I've been looking at and what I've been trying to assess is to sort of look at, the most importantly right now, the death is due to patients who have an underlying medical condition. So when you examine the underlying medical condition that's listed by the New York City Department of Health and Mental Hygiene, it states that some of the conditions are preventable or manageable conditions that they have as underlying medical conditions, and that's diabetes, heart disease, asthma, hypertension, right? Just these are the chronic diseases that we work to address as public health practitioners, as public health professionals, in communities, throughout the country, specifically in New York and in Queens. So when you look at these underlying factors, and knowing also that the coronavirus belongs to a family of viruses, such as the SARS, the severe acute respiratory syndrome, as well as MERS, Middle Eastern respiratory syndrome as well. So when you look at, it belongs to those families, and when you look at the prior research and publications, it pointed to that death were more likely occurring among those with the similar underlying medical condition.
And many of those conditions are found in a densely populated community like Queens County, correct?
Yes. So a lot of, I think over 30% of the U.S. population has these underlying medical conditions, right? So just look at Queens being very densely packed, very densely concentrated, and there are also disparities within Queens. So what we're hearing now that in the media that the populations of communities that are communities of color,
correct,
such as Blacks and Latinos, is affecting them more.
Access to testing and the medical care that a lot of these folks have or don't have.
Right. So when you look at, even before the pandemic, managing these chronic diseases and access to health care has been an issue in some of these communities. So when you have a community, for instance, with a underlying medical conditions that are where they're unable to manage, and then you add, a highly infectious disease that's affecting them, then more than likely the outcome may be where what we're seeing now, where it's a heightened increase of death in the community. Now, another thing to look at is whether or not the messaging was clear, and whether or not the government officials or the public health community really worked quickly and in educating, informing, or bringing the awareness of the population about the disease. And it's not just Queens, it's the entire New York City community, right? Or even the state. What did we do to educate them? This is, we're experiencing this, and this may be coming to us. If it does come to us, this is what we advise, and this is what we do, given what occurred in the past with MERS and SARS. Now, there may be some issues with that, or a fine line, because it's a new disease. It's a novel coronavirus. So you have to sort of juggle between a new disease where there may be new characteristics about the disease that we're not familiar with, that may not be as that may be different from MERS and SARS, but also it still belongs to the same family. So what the CDC did was they used what the recommendations were for MERS and SARS as a recommendation for COVID-19, until we have new science, we have new information, and new results on what we're doing, the studies that we're doing with COVID-19. So I think information sharing is number one. We could have done a better job at in terms of sending the message out there. For instance, we cannot all rely on social media. The elderly, for instance, who are at very high risk for this disease, immunocompromised, certain communities, immigrant communities may not access the type of news media that we may access, you know, the sort of the primetime TV. They may use their, you know, more cultural radio stations or TV stations. So we can't rely on one source of information. It must be redundant,
right,
and it must be interoperable. It must not just be social media, or, I mean, we should have had healthcare alert notices posted in communities throughout New York City. If we know that the disease is affecting, you know, those with underlying medical conditions, as what I mentioned earlier, we could have targeted these communities with these high elevated underlying medical conditions, or at least mention it in the early onset of the outbreak. In addition to that, there are, so I talked about the health alert notices. Another thing too for us to determine is that what is our capacity and capability in terms of the healthcare infrastructure? Do we have, say, enough vents? And if so, do we have extra? And if we don't, then how can we get the extra ventilators, for instance, or the a shortage of blood supply, or mask and gloves? It shouldn't be, in my opinion, that we had to run out of it, and the you know, the public bought a lot of it from the pharmacy and other healthcare stores. But my point is that the healthcare workers, who are the ones to protect us and treat us, are the ones who are, you know, their resources have been depleted.
right.
And now we have to sort of struggle to find ways to sort of beg for ventilators, for you know,
PPEs.
For basic PPE,
right,
you know, to protect them. Because you know, I don't know for anyone else, but I've used those masks in a response. And you know, there's only so much you could put that mask on.
right.
Unless you need a break, you need to change the mask, it may wear out. You know, other PPE, you know, gloves and the whole suit as well. You know, we had to do this during the Ebola response.
So communication, infrastructure are two things moving forward that we could try to do better or learn from this outbreak for the next one.
Yes, and there was one more: syndromic surveillance. Syndromic surveillance, looking at when we say we know that we're going to expect this disease to come into the community, right? We tried our best to stop the introduction by stopping flights, but guess what? The disease was already here, and quite often that happens, right? So now that the disease is in the community, we should have done a better job to do what's called syndromic surveillance. And right now, I know they do, it exists, syndromic surveillance, whereby hospitals and healthcare institutions they will report the number of, say, flu-like symptoms, or, you know, and that happens on a daily basis. But what we should have done with this, in my opinion, was that perhaps consider doing something where you do syndromic surveillance, where right now, looking at a patient who comes in at the hospital with suspected coronavirus signs and symptoms, then you contact those individuals that the patient may have been exposed to, and you do the surveillance to those individuals. So I'll give you a perfect example. During the Ebola response, what we did, we handed each passenger that came through from an Ebola-affected country a cell phone, a chart to manage their signs and symptoms on daily basis if they were to exhibit these signs and symptoms, and contact information and a toolkit on what they can do and how they can prevent the spread of it and what they should do in the event they would exhibit these symptoms. They were given that for, I believe, 2 weeks or more. Then they were given information for each health department at their final destination, like the city or state health department. So my point is that on the onset of the virus, once we start getting cases, positive cases or laboratory confirmed cases, in my opinion, I think we should have done a little bit more aggressive approach into identifying your contacts, those who you live with, those who you've been in contact with, what your job, your occupation is, whether or not you traveled before, and see what is your living condition, right? Do you live with 10 family members in a household? Do you live with grandma or grandpa or your cousins, which is very common in Queens, right? Especially among immigrant communities. So if you live in a tight infrastructure, do you have the capacity to socially distance? Do you have the capacity to isolate? So these are some of the things that we need to sort of think about moving forward when we're thinking about a pandemic situation.
Right. And as I recall in this situation, at least in the very beginning, when we saw that cluster up in New Rochelle, there seemed to be some efforts at that tracing that you've talked about. But then as it just grew and grew, I think we heard less and less of that, and it was more trying to mitigate.
Yes, and so that's where, again, another fine line where now it spreads so much and so fast into the community, then how do you then begin to mitigate? And then, you know, we were told not to wear masks and gloves outside. Now we're told it's advised that we do wear masks and gloves outside. Now that's a very classic public health scenario where, you know, you had the National Guard come in to the community in Westchester and try to contain the virus, right? Now that it's sort of community spread and it's in the community, then what do you do? I think, though, there still is something that we can do, and it's specifically for those who have an underlying medical condition to prevent death. So perhaps we can, you know, number one, assess whether you have, okay, so for instance, say I come in and I'm positive with from coronavirus, and say, you know, I live also with, you know, my grandmother, you know, so in the assessment, then determine, okay, so you live with your grandmother, well, you would have to isolate from your grandmother because you don't want to get it because it's a high, you know, risk for her to get it and die from it. Or say I'm living with someone who is immunocompromised or have cancer, or say I live with someone who has uncontrolled diabetes or hypertension. So my point is that perhaps we can do these assessments to determine, okay, so let's prevent death at least, and see how we can either separate these individuals or provide the personal protective equipment to protect them or their loved one.
My last question for you, after 9/11, there was a resurgence and a great interest in people looking to pursue public careers, whether it's firefighters or the NYPD. Do you think as a result of this pandemic that there will be a greater awareness of the opportunities in public health, or a calling for more people, students that may be in your classroom right now, to get involved in public health in the long term?
Absolutely, absolutely. And, you know, you raise a very good point that I think it's important for us to address. And I commend the law enforcement community for really stepping up in this response, and specifically fire and police officers, because they're not trained to be public health workers. When we did the Ebola response, we worked with the Department of Homeland Security. So we would work very closely with the customs officer, and they did a remarkable job in doing the initial onset of screening. And they would refer the passengers to us to do more detailed public health evaluations. As much as we know that the law enforcement, as well as fire and other security agencies, we know that they're not clinicians necessarily, or they're not, as I mentioned, public health workers. They really do a great job that I have observed with control communities. I'll close with this. Tremendous opportunities for our law enforcement, our firefighters, and other professionals in the industry, even in the corporate industry as well, where there needs to be much more training and sensitivity and understanding on how to protect ourselves, our communities, and our loved ones.
Thank you for that, and thank you for your time today. Dr. Harlem Gunness, a great example of faculty from St. John's who bring their personal and professional life experience to the classroom. I want to thank you for your time today, and so much more we can talk about, and we'll continue to have this conversation. But I think you make a great point that we can all now, in our own way, become better informed and better public health safety officers in our own lives, and that can only help the greater community at large.
Thank you very much.
Thank you for your time, and we'll see you next time on Spotlight on St. John's. Today at St. John's University, faculty, staff, and administrators came together and collected excess classroom medical supplies, and we just donated it over to New York Presbyterian Hospital, Queens. Right now, our students are learning virtually, so this is material that would have been used in the classroom. Instead, we're giving it to those most in need, our emergency healthcare providers who are in need of PPEs, personal protective equipment. You know, St. Vincent de Paul was a great community organizer, and he was once asked a question that he then turned around and proposed to his followers: what must be done? Today, St. John's saw a need, and we answered that question of what must be done. A great collaborative effort, the whole St. John's community coming together, partnering with New York Presbyterian Queens to make something positive happen during a troubling time.